So, welcome to this short section on ventricular arrhythmias. As I was going over the topics and thinking about what was important for the entry level pharmacist to know about ventricular arrhythmias, I thought that maybe this topic, being a small and somewhat concise topic, would lend itself well simply to an online session. Really, what I want folks to focus on is not to recognize rhythms on a rhythm strip or an ECG, but be able to understand some of the common ventricular arrhythmias, what the problem is, what the adverse effects of the common drugs used to treat those would be, help to be able to prevent those adverse reactions, and then, of course, looking for things like drug-drug interactions or patient complaints, and evaluating the prescriptions and medication orders that might be written for common antiarrhythmic drugs. One of the things that I was going to show you before we get started is an online tool that I've found very useful. I put the link on here. I'm going to drag this over into the window so you can simply see what it is. This is it's an online ECG simulator or rhythm simulator, so you can put different types of rhythms up there, and you can look at those. So I'm going to turn the sound off because it gets kind of annoying after a while. So I don't expect you to go and memorize certain rhythms, but as we're talking about a rhythm, for example, when we talk about ventricular fibrillation and you want to think about what's happening, you can click on that, and not only do you see the rhythm, you can stop it with the mouse, you can look at it, but you can also go down here and look at a brief description about what that rhythm is about. And so a useful tool, and I may use that some as we talk about the different rhythms, just to help orient you to the rhythm that we're talking about. So next I've got a slide that's just some basic definitions about the rhythms that we're going to look at. What is a PVC? Ventricular tachycardia, VFib. I've introduced the concept of torsades de pointe, which is a French term that basically means rotation around the axis, and you'll also hear me call that polymorphic VTAC or polymorphic ventricular tachycardia. Sinus bradycardia, bradyarrhythmias are fairly common. We'll talk about those. And then AV nodal blockade is something that we can cause with our drugs, particularly beta blockers and or non-DHP calcium channel blockers. So I think it's important that we spend a few moments talking about those. Let's begin with a conversation about PVCs, or premature ventricular complexes. These can be benign. In certain patients, they might be concerning. Basically, what happens is you simply get a premature depolarization of the ventricle. And so I'll pull the ECG simulator. We'll look at a sinus rhythm with a PVC. And what you'll see is every now and then you'll get a complex that looks a little different. For example, right here. What you're looking at is a QRS complex that there's no P wave that initiated that. Because of that, it's not a clean depolarization down the fiber system like we would typically see, so we see a wide complex there. Patient goes back, normal sinus rhythm, P waves, QRST, PQRST, PQRST, and here's another PVC. Typically, these won't be seen commonly. It's something that might be seen. You may have one or two PVCs in a 24-hour period, for example. So oftentimes in young, healthy patients, these can be benign and are not a primary concern. In patients that are older or have underlying structural heart disease, so for example, maybe a patent foramen-ovale or some type of atrial septal defect, perhaps they've had a recent MI or are having an MI, this could be very concerning. So the treatment could be that you do nothing for a healthy asymptomatic patient, to treating with beta blockers for someone undergoing ischemia and acute MI and having some PVCs, to someone with structural heart disease and would be significantly at risk of sudden cardiac death, may need to be placed on an antiarrhythmic drug to suppress these. as we talk about PVCs, I think it's good that we talk about the CAST trial, and you've heard me talk about this before. And my goal here is not that you memorize a name of a trial, but I want you to recognize that this was a very pivotal point in medicine from an evidence-based medicine standpoint. Because one would think that when you see something, a wide complex on an ECG that's abnormal, that this would be a bad thing for the patient, particularly if that patient has recently had an ischemic event such as an MI. And so in the late 80s, the National Institutes of Health initiated a study looking at patients who suffered from PVCs within the last 2 years from the time they were enrolled in the trial, and they also required that those folks had a reduced left ventricular ejection fraction. So they had some residual decreased left ventricle function because of their ischemic event. Those patients were randomized to various class 1C antiarrhythmic drugs, which were the drugs of choice at this point in time for suppressing PVCs in these types of patients. Within 2 years, Inconide and flecainide have both been discontinued, those arms of the study, because of an increase in mortality, meaning patients were dying faster in the AAD arm of the study than in patients who weren't receiving antiarrhythmic drug therapy. And within 4 years, the merizocine arm was also stopped. So the point of the CAST trial is that it was a pivotal time in medicine in general, and particularly cardiovascular medicine, that made practitioners stop and really look at the evidence, because just because we can fix a number, or we can fix a symptom, or we can fix something physiologically today, doesn't mean that it's in the best interest of the patient tomorrow and in the future. I will say that, now this is not an outcome of the CAST trial, but to kind of summarize how would we deal with folks who might need therapy, who had an ischemic event, who had a decreased ejection fraction, and might be at an increased risk of sudden cardiac death. Amiodarone and dronedarone are two AEDs. They're the only AEDs that have not been associated with an increase in post-MI mortality, which means that every other antiarrhythmic drug that's been studied post-MI has been shown to increase mortality. These drugs don't decrease mortality, but they look like they're mortality neutral. So in these patients that might need to be treated with an antiarrhythmic drug because of a ventricular arrhythmia secondary to ischemia, only amiodarone and dronedarone have been shown not to increase mortality. So my point is these drugs can, in general, antiarrhythmic drugs can be highly proarrhythmic as well as antiarrhythmic. Anytime you're messing with the conduction system of the myocardium, you're going to put the patient at risk for an arrhythmia. So now let's talk about ventricular tachycardia. Ventricular tachycardia is a wide complex arrhythmia. It has a wide QRS. I want to show you off of that the rhythm generator. I'm going to pull that over and show you a VTach rhythm. Now, this is very concerning. You can look at this and see it's abnormal. What you're seeing there is QRS with no P wave. So basically a very rapid depolarization of the ventricle. This is not going to sustain life for very long. And in fact, in many patients, they may not have a pulse. And that's one of the things that I've differentiated here on the slide is pulseless VTach is a completely different rhythm than VTach with a pulse. Pulseless VTach is going to be the same as ventricular fibrillation, where the ventricle has just a sporadic electrical activity and does not contract. It basically quivers, just like atrial fibrillation. But with the left ventricle, we're not perfusing our organs. We're not getting blood supply to the rest of the body, and so that patient will die. Pulseless VTach is treated the same as ventricular fibrillation. But for patients who have maybe a short run of VTach, so a sustained versus non-sustained VTach, those patients we may just need to treat them symptomatically. Patients can experience short runs of VTAC from time to time that aren't life-threatening, at least not immediately life-threatening. However, patients likely are going to be symptomatic during a run of VTAC, and so these patients will likely be treated with antiarrhythmic drug therapy unless it's a reversible cause. So what I mean by that is, let's look at polymorphic VTAC. So monomorphic VTAC is what I showed you on the monitor. Polymorphic VTAC, also known as torsade de pointe, is oftentimes caused by an acute event, such as hypokalemia, severe hypomagnesemia, or a hypoxic injury. Drug toxicities like digoxin can also be a cause of polymorphic VTAC or torsades, sometimes acute MI. So my point would be that if we have a patient, say, suffering from an acute MI and experiencing VTAC, whether it's monomorphic or polymorphic, a beta blocker might be a very reasonable treatment for that patient. They may need antiarrhythmic drug suppression for a period of time after their MI as well. Whereas a patient with hypokalemia, if we correct the potassium deficiency, they may not need any long-term therapy with an antiarrhythmic drug. So again, the crutch is going to be, does the patient have a pulse or not? And is it something that's sustained? So is the patient suffering the rhythm for more than 30 seconds? That would be sustained VTAC and would likely need long-term treatment. Non-sustained VTAC might also need treatment, but typically you're going to look for reversible causes of that. So we're going to focus on the chronic management here. You're going to learn more about things like pulseless VTAC and ventricular fibrillation and PEA, pulseless electrical activity, and some of the more acute rhythms in the critical care module next year. So let's talk briefly about VTAC, or the treatment of VTAC. So with polymorphic VTAC, and before we get into treatment, I'm sorry, let me make one other comment about this. So this is a torsades de pointe that I've talked about, which can be life-threatening. Patients who go into torsades often have a poor prognosis, and so this is certainly something that we would want to avoid. Any drug that causes delayed ventricular repolarization is likely to cause torsades. Specifically, the drugs that classically are associated with this are going to be your class 1A antiarrhythmics, such as quinidine. So quinidine can actually, and too much is given, cause polymorphic VTAC or torsades, as well as our class 3 drugs like sotalol that we've already talked about. Drugs like dofetilide are known to prolong the QT and can cause torsades. So one thing that I wanted to point out here is when we're dealing with drugs that prolong the QT, effects on QT prolongation are often additive. So what I mean by that is if you have a patient that is on dofetilide, or you have a patient that's on sotalol, and you add another drug such as a quinolone antibiotic or macrolide. So how many prescriptions do you see for Cipro, for levofloxacin, for azithromycin come through your pharmacy? That patient who is on a drug like sotalol, in addition to a macrolide or a quinolone, is at an increased risk of this. So that might be a significant drug interaction. This is probably something that as a pharmacist you'd want to at least consider notifying the physician of. Did the physician recognize the interaction existed? The physician may very well have information such as a ECG on file that shows the QT intervals fine. But if they don't, then the patient is at an increased risk of torsades when you combine QT prolonging drugs together. While I didn't specifically mention this in the slide, I'll write a number up here for you, and that number would be 500. So that's there's some other numbers you can know. Is it male versus female? And you'll learn more about that in critical care. But if a patient has a QT interval of approaching or greater than 500 milliseconds, that typically is when we become worried about that. So as far as treatment goes for VTAC, the primary antiarrhythmic drug used for that is going to be amiodarone. Now, one thing I wanted to introduce here, in addition to antiarrhythmic drugs, is that some of these patients, for example, patients who've had multiple runs of sustained VTAC, what clinical evidence has shown is that implantable cardiac defibrillators, or ICDs, are actually superior to our antiarrhythmic drugs for the prevention of sudden cardiac death. In fact, patients such as those with heart failure who have an ejection fraction of less than 35%, typically these are going to be our functional class 2-3 patients that are symptomatic. You'll learn more about that in the upcoming week. But those patients with heart failure, who have a decreased ejection fraction, less than 35%, their myocardial activity is such that they are at a significant increased risk for sudden cardiac death. So when we have patients with conditions like VTAC or are at an increased risk from other causes, from sudden cardiac death, oftentimes the ICD, or implantable cardiac defibrillator, is going to have a higher net benefit than an antiarrhythmic drug. And in fact, the insurance companies recognize this, and it's a covered treatment for those folks. It's not a cheap treatment, but what is the value of a human life? These things can easily save lives. So you're going to see more and more, as we have more evidence in certain disease states, you're likely going to see more of these non-pharmacologic treatments used as a cornerstone of therapy, because our antiarrhythmic drugs, let's face it, they're not all that effective and are fraught with side effects. So, changing gears a little bit, we talked about a couple of tachyarrhythmias. Let's talk about bradyarrhythmias from a ventricular standpoint. So we talked about some different types of atrial arrhythmias. The focus of this is really ventricular arrhythmias, hinging on recognizing appropriate drug therapy, side effects, etc. But I think it'd be important to talk about just simply sinus bradycardia, which is not all that uncommon, particularly in young, healthy athletes. Folks that are highly athletic, do a lot of running, competitive athletes. They may oftentimes have low heart rates at baseline. Usually they're asymptomatic, and that typically is benign. It's almost like a marker of good health. Whereas that same heart rate in an elderly patient, it could be indicative of the effects of time and effects of physiologic changing due to age on the SA node, resulting in some type of SA nodal dysfunction that prevents the appropriate stimulation of depolarization. In these elderly folks, you'll also sometimes see something known as tachybrady syndrome, where the patient's autonomic regulation is such that they will become bradycardic, but then they may compensate but become overcompensated, and that would induce tachycardia through the release of drugs like catecholamines, epinephrine, norepinephrine, etc. So endogenous drugs, if you will, or endogenous substances. So typically for bradyarrhythmias, your cornerstone of therapy is going to be pacemaker therapy. So the patients with tachybrady syndrome can be concerning, because they might need to be on a beta blocker at some point, or a calcium channel blocker at a slow heart rate. But then when they become bradycardic, that could put them into heart block, and it could stop the conduction across the AV node. And so a pacemaker, what that does is it maintains the patient's baseline rate. So a pacemaker is different and separate from what we talked about previously, the implantable cardiac defibrillator. An ICD shocks the heart, literally shocks the heart from the inside if it detects life-threatening rhythm, such as VFib or sustained VTAC or torsades, so polymorphic VTAC. Whereas a pacemaker is simply assessing the patient's rhythm, and if the rhythm drops to below a threshold, usually around 60 to 65, maybe 70, but usually in the low 60s, then it's going to stimulate a depolarization of the ventricle, so that the patient can continue to perfuse and be asymptomatic. So patients typically don't know if their pacemaker is functioning or not. They'll feel normal because the heart is able to perfuse tissue normally. Now, I've mentioned this concept of AV nodal blockade, and I thought we would spend a few moments talking about that, simply because AV nodal blockade is something that can commonly happen with drug therapy. I'm going to throw our rhythm simulator back on the screen here. And just real quick, I'm going to show you a normal sinus rhythm with first degree AV block. I mentioned this previously when we were talking about AFib. And what you'll notice is your P wave is separated from the QRS complex. So your P R interval is prolonged, but you'll notice that it's uniformly prolonged with each depolarization. When we go into a Mobitz type 1, or I'm sorry, a Mobitz type 2 or a type 1 second degree AV block, this one, and what I'm trying to illustrate here is a progression, so we'll use the type 1. The type 2 is a little more confusing. But what you see is, if you look at that same PR interval, we'll notice a somewhat prolonged PR interval, a more prolonged PR interval, an even more prolonged PR interval, and then a period where we have a P wave, but we have no ventricular depolarization. The myocardium's not reset. It's only repolarizing here. And so it can't polarize secondary to that P wave. So in essence, what we've done is we have dropped a depolarization. We've dropped a QRS. We've dropped a beat of the left ventricle. Then the process starts over. We get a depolarization, a little bit prolonged, more prolonged PR interval, and then another dropped QRS complex. So that's a common type 2 AV nodal blockade. And there are different subtypes as well. But just to illustrate, though, a third degree AV block, the problem with that is that notice the rate of 36. Patient cannot sustain life too long. The average patient can't when their heart is only beating 36 times per minute. They're not going to perfuse their brain. They won't perfuse their organs. What you're seeing here is a complete dissociation from any P waves and depolarization of the ventricle. There is a P wave here, but what you'll notice over time is that the QRS complexes are not routinely associated with the P waves. So basically you have a complete dissociation between the atrium and the ventricle. The atrium's depolarizing, but the ventricle is depolarizing on its own, and the escape rate, typically that the ventricle is able to depolarize without stimulation across the AV node, I think of a number of around 40 as a typical rate, and here you see that illustrated as a rate of 36. So you can imagine you're not going to sustain life, and you're going to have symptoms if your ventricle is only depolarizing 30 some times a minute. The drug therapy for this is typically something like atropine that would cause an increase in the heart rate, and then transcutaneous pacing is going to be employed if necessary. So what that basically means is they put pads on a patient's chest, and they use a small electrical signal to cause depolarization of the ventricle. And so this can be uncomfortable for the patient, but it can be a bridge to a more invasive implantation of a pacemaker if needed in an emergent situation. So for the pharmacist, what I would really encourage you is we should be screening folks to prevent this. The last thing we want to do is cause AV nodal blockade with drug therapy. So again, it's going to be our beta blockers and our non-DHP calcium channel blockers that we typically are going to worry about. So as we wrap up, I wanted to spend a little bit of time talking specifically about some antiarrhythmic drugs. So I gave you a brief synopsis, brief overview there of some common ventricular arrhythmias, very much a survey of those. I gave you a tool you can use to look and assess rhythms and learn more about them if it interests you. And then I also wanted to spend a little bit of time talking about the drugs themselves. We talked about the CAST trial and the problem with the 1C antiarrhythmics. But remember that all antiarrhythmics can be proarrhythmic. Typically, for ventricular arrhythmias, you're going to see a class 1 or a class 3 drug used, and you're going to want to initiate those in an inpatient setting with monitoring. These drugs have lots of adverse effects, and oftentimes we don't know how a patient's going to respond. Is this patient going to develop a prolonged QT interval on this drug? We don't know. So the way we initiate that should be in a controlled environment with the patient on telemetry and appropriately trained staff available. So basically in the hospital. We would do that until the patient's on a maintenance drug. Typically, about 3 days would be a reasonable admission for initiation and titration of antiarrhythmic drugs. Now, there's other drugs such as amiodarone that oftentimes will be started in the outpatient setting, particularly for things like atrial arrhythmias, atrial tachycardias, those types of things. Um, but what I want you to know are drugs like dofetilide. I would argue perhaps even sotalol in some patients. Drugs like propafenone, those should be initiated on the inpatient setting. Now, I'm going to come back to amiodarone. I've got a slide on that because it is a fairly complex drug. And before we move on to amiodarone, I just simply want to point out a little note about dronedarone. So amiodarone, fraught with toxicities and side effects. Dronedarone was a drug that lacks that structural similarity to the iodine and the thyroid receptor. So you get some of those, you get less of the iodine structure related side effects with dronedarone. So the goal was something that's as effective as amiodarone without the amiodarone toxicities. The drug was primarily deployed in patients with atrial fibrillation and heart failure. And unfortunately, what we saw over time in clinical trials was an increased mortality in patients with concomitant heart failure and AFib. So dronedarone is not a drug that's commonly used. Most folks nowadays, we want to avoid it with atrial arrhythmias, and with ventricular arrhythmias, many folks will simply prefer amiodarone. And so as we talk about amiodarone, there's tons of information out there about the toxicities of amiodarone. One of the things I want you to know, you're going to have to know this. It comes up. It will come up. You may not realize it comes up because you might not know the information. But that patient, for example, with COPD in that new prescription for amiodarone, if you don't know that amiodarone causes pulmonary toxicity, you may not know to tell that patient or inquire of that patient whether or not they've had baseline pulmonary function testing done. That patient comes in after 6 months of amiodarone with a refill for albuterol and some other inhaled medications with COPD and is complaining about how their drug's gotten significantly worse over the past 3 to 4 months. You should be able to recognize that amiodarone could be the root cause of that. So without baseline PFTs, how do we know what the patient's pulmonary function test should be today and whether or not it's due to increasing disease or maybe related to that amiodarone initiation? So there's things like that are important for the pharmacist to know. Things like monitoring of LFTs. If the liver enzymes, the AST and ALT elevate, then we'd have to stop the drug. There's a good review article and list of side effects. Now, I think you should be able to access this at any location, but I will give you a disclaimer that you might need to be on campus to access this resource, but you can try it at home, and I think it will work. It's a really nice review, very quick, with some nice tables that list these common adverse effects as well as common monitoring labs, and I would like for you to review that. I think it's information that you might even want to file away because I can promise that you'll see that again in practice. And during your 4th year. I just would point out that some of the side effects with amiodarone are dose dependent, whereas some of those are independent. So some side effects of amiodarone can't be avoided regardless of dose, whereas other side effects may actually be relative to the amount of time the patient's been on the drug as well as the total cumulative dose. So my point would be that if you have toxicities that are dose dependent, it's reasonable to always use the lowest dose possible. So for example, you don't need 800 milligrams of amiodarone daily for an atrial arrhythmia if that's what you're using it for. But it may not be unreasonable for 800 milligrams, probably a minimum of 400 milligrams for your common ventricular arrhythmias. So if you see a patient on a higher dose of amiodarone, it might be worthwhile just to simply ask them if they know why they're on that. If they can clearly tell you because they have AFib and they're on 400 to 800 milligrams a day, it might be worth advising them to consult with their physician about reducing the dose to reduce the risk of some of these side effects. So again, I would like for you to take a few moments of your time, look at this article, read through the tables, and just recognize all of the various toxicities that are associated with amiodarone. And that should be somewhat of a review for you from pharmacology as well. Now, sotalol is a drug that we've talked about previously as well. The thing that I thought I would mention is we talked about how sotalol is a class 3 antiarrhythmic drug that also has some beta blocking activity. The reason that is because sotalol, as most drugs are, is a racemic mixture of the active ingredient, the D and L isomers, which both inhibit potassium channels, exerting that class 3 activity. However, the L isomer also has the class 2 activity, or the beta blocking effects. So note then that it's only half of the active drug, so D and L being roughly equivalently represented in a racemic mixture, meaning that half of that substance has some activity as a beta blocker, but all of that substance has primary activity as a potassium channel blocker. So again, just reinforcing that sotalol is a class 3 antiarrhythmic drug with some class 2 activity. It does prolong the QT interval, as many class 3 drugs do, and so you need to watch for that. Amiodarone has class 3 activity and prolongs the QT interval. Sotalol is a renally eliminated medication. We talked about the fact that it may require a dosage adjustment, and something that the pharmacist should be evaluating in their patients. So I know that we had just a small amount of time set aside for ventricular arrhythmias. So really my goal was to point out some topics that would be relevant and important for the practicing entry-level pharmacist, folks who are going to be evaluating prescriptions or medication orders for patients suffering from these conditions, and recognizing some of the common drug issues that we might face. Just a reminder that any of these antiarrhythmic drugs can be proarrhythmic, and they should be used cautiously. Really, these should be prescribed by prescribers that have training and experience. So, for example, ideally, if you're using a strong antiarrhythmic drug such as dofetilide or amiodarone, it would be good to have that patient under the care of a cardiologist. It would be important for the pharmacist to be able to recognize common adverse drug events for the commonly used AADs, and also to be able to provide appropriate patient counseling, either independently of or because of things you've recognized from the patient's profile, for example, drug-drug interactions, or from things the patient might ask you. Drug-drug interactions are a big deal with antiarrhythmic drugs. We talk about the fact that drugs cause an accumulation of other drugs, and for example, if we had a medication that increased our exposure to statin therapy, for a patient on a low or moderate dose statin, it may not be an issue. For a patient on a high dose statin, perhaps it increases their risk of muscle pain. But for a patient whom we increase exposure to an antiarrhythmic drug, we might kill the patient. The patient could die from an arrhythmia. So these are drugs that the pharmacist should really pay attention to when you see these prescriptions come across your counter in the pharmacy or your terminal in the hospital processing those orders. I hope this has been beneficial, and I will look forward to continuing our cardiovascular discussions on heart failure as we wrap up this module or this course in the curriculum. Thank you.